Sure. I'm going to read. Good afternoon. My name is Robert Vander Stichele. I'm a retired general practitioner in the city of Ghent in Belgium, Europe. But I was also a certified clinical pharmacology, teaching the art of prescribing to medical students. And I have had a scientific career with publications in a number of domains. One of them being drug utilization and appropriateness of prescribing. And that's also the topic of today, quality of medication management in nursing homes. Next slide, why? Honey. First, a small overview of what we're going to talk about. We're going to briefly touch upon the problem of polypharmacy in older adults, then ask ourselves how can we assess potentially inappropriate prescribing. I will say a few words about the Belgian pilot study in nursing homes on this subject, and then dwell a little on the problem of quality of clinical data on residents in nursing homes. How much do we know about the residents in nursing homes? How good are the medical records? And are they good enough to really evaluate the quality of prescribing? And then we'll end with some thoughts about the mortality of COVID-19 in nursing homes. As you know, that was the place where the biggest toll for this disease was paid. Okay, let's start with the problem of polypharmacy in older adults. In the developed world, 10 to 15 to 20% of population is 65 and older and growing. And when I ask students what the percentage of that 20% of 65 plus is that resides in nursing homes, I usually get answers in the order of 50%, 60%, but in reality it's 5 to 8%. The majority of the elderly population is still community dwelling. But 5 to 8% of the 65 plus reside in nursing homes, also called long-time care facilities. In some countries, these are real home replacing livings. In other countries, just places to die. Up to 50% of the residents in such homes are cognitively impaired, and this population constitutes then about half of the total demented population in the country. So half of the demented are in the nursing homes, and in the nursing home, they are half of the population of the residents. The life expectancy in the entering a nursing home is less than 1 year to 4 years, with some exceptions, but live longer. And for 1 into 2 citizens going to a nursing home and die there is the end of life trajectory. Many of these people have multiple chronic diseases, and most of them have polypharmacy, meaning that they consume 5 or more medications, but not just medications, chronic medications with a systemic action. So we don't count the ointments, the drops, and all the other small, more trivial things. Of the community dwelling very old, 80%, more than half present polymorbidity and polypharmacy. And here we have a graph from a little study that we did in Belgium about the prevalence of potentially inappropriate prescriptions in community dwelling older adults. As I said, 85%, 58% has polypharmacy, but when we also look whether they present medications that should not be taken because they are inappropriate, and it's 56% who has at least one. And if we look at their diseases and say, are they getting all the medication that they should have, then in 67%, at least one medication is not given. And there is a serious overlap, 31% who present and polypharmacy and misuse and underuse. So it's a complex study, a complex issue, difficult to manage, and I would compare the prescriber doing a very difficult exercise and balance in trying to navigate between the risk of polypharmacy, the risk of inappropriate prescribing, and the risk of not treating the patients as they should be treated. How can we assess potentially inappropriate prescribing? That's the next part. Well, we can ask clinical experts that they go to the nursing homes and assess the medical records and the medication lists. That's manual work. They can do it in an unstructured way, or they can do it in a structured way. And for that, we use the medication appropriateness index, the MI, which is about 10 questions for each medication line. And as you know, they have 8 to 10 lines. That means 100 questions per patient. So you can imagine that is time consuming. Or they can use validated lists of explicit criteria. One well-known example is the Beers list from the US, and another from the EU is the stop-start list. It's also time consuming to do that manually. And for routine care, the expert resources are simply not available. And the second approach is by combining multidisciplinary medication review with ICT assessment of potentially inappropriate medication, short PIMS. So let it help the computer to pre-screen the patients and then present the results to the nurse, to the pharmacist and the doctor. And the pre-screening of the computer is based on an automated version of the Beers list and the stop-start list. How do we do that? How can we turn this explicit criteria of inappropriate prescribing into a decision rule? Well, these decision rules are mostly built upon in a schema that if a certain condition is present, then this would be the message because there is a reason for that. And let's illustrate that with an example. If a specific disease is present or a specific drug is present, then a specific inappropriate medication should be stopped or reduced in dosage, or a specific appropriate medication should be started. And why? Well, two possibilities. There may be evidence for this advice. So we live in the age of evidence-based medicine, but it can also be that there is not really evidence, but an expert panel has said so, that this was appropriate or inappropriate to do. But logically, this is how these criteria are built and into decision rules for computers. And of course, then these decision rules need to be coded. The diseases in the rule can be coded by the International Classification of Primary Care, the International Classification of Diseases, or SNOMED-CT. And the medications, we can code them with ATC. ATC being a rather granular but very handy system where we can also identify groups of pharmacotherapeutic groups, because these rules are very often of a general nature. If a disease is heart failure and the medication is an NSAID, a non-steroidal anti-inflammatory drug, then we should launch the alert to stop the NSAID. People should not take NSAIDs when they have heart failure. And this can then be translated in computer language if the SNOMED code is 8411 and so forth, and the ATC code is M01, and that will lead you to any NSAID, then launch the message 5.6.2, meaning please stop the NSAID in this patient. How are these explicit criteria validated? Well, mostly they originate from expert panels using Delphi methodology. Not all these criteria are really evidence-based by evidence from clinical trials under detailed specific for that criteria. And validation as such has only been done for the complete lists, not for the individual PIMS. In cross-sectional observation studies, in longitudinal observation studies, and in randomized trials, it was clearly shown that the score on such list correlates with higher mortality, more hospitalizations later on. And so the validation is for the list and not for the individual PIM. There is a difference between quality indicators and PIMs. Quality indicators, which we know from the audit and healthcare research, are derived from large administrative of clinical databases, so from big data, and they provide us with an idea of the quality of the population of prescribers. How well are our GPs doing in a certain region? PIMs need excellent individual medical records or patient summaries, and they provide an idea of the quality of the individual prescriber working for an individual patient. And then, of course, each of the individual assessments can be aggregated to higher levels. Can you hear me well? Oh, is that okay?
Yes.
Yeah, okay. Then the next chapter, decision rules for improvement of pharmacotherapy with medical audit based on PIM criteria. I would like to give you some examples. For instance, explicit criteria for inappropriate prescribing, for misuse, so the use of inappropriate medications. The classic example is amitriptyline in a dosage, that's an antidepressant, a classic tricyclic antidepressant, and should not be given to elderly people in a dose higher than 75 milligrams. This is a rule and a decision that you will find in each of the three lists. In Beers, you will find, in the Beers list, you will find another rule that if the patient has heart failure, he should not be treated with diltiazem. On the other side, the rules for underuse is, for instance, patients receiving opioids regularly should have a laxative. If opioids are on their list and there is no laxative, then we will raise a red flag. If the patient has a documented history of coronary, cerebral, or perivascular disease, so secondary prevention of cardiovascular disease, then antiplatelet should either aspirin or clopidogrel or prasugrel or but at least one of these four should be given. And that's the rule from START. And START is the only list that looks at underuse. All the rest only looks at misuse. So there are three important lists, as we said. The Beers list is from American origin, requires and medication data and clinical data, is the one who has most validation studies, and has a single focus on misuse. EU7 is from European origin. It requires only medication information, so that's easy, but it's also superficial. It's scratching the surface and not going into the depth of clinical care. And it only focuses on misuse. Stop-Start is probably from European origin, probably the most advanced. It requires clinical data and medication data. Stop focuses on misuse, and START focuses on underuse. We have selected all these criteria from these three lists, and that's about 650 explicit criteria. And then concatenated that into one big repository that you can search and manipulate for type of drugs or type of diseases, degree of validation, and things like that. The publication is listed, the reference to the publication is listed at the end. Okay, some examples of PIMs in heart failure. For instance, the Beers criteria of misuse in heart failure. If you have heart failure, you should not use thiazolidinus, not use silastol, not use dioxin as first-line therapy, etc. Okay. I will not record all, but this is the complete list for patients with heart failure, according to Beers. This is according to STOP, and there's one page, and the next page is also You see that these criteria are much longer, more complex, um, uh, have about have elements of severity of the disease, um, require much more clinical data, like data on the systolic function, um, etc., etc. So you see, it's quite more complicated. And here is the rest. So, and the question is, okay, you can give that to cardiologists and GPs and send them to the nursing homes and try to assess this, but can a computer do this? This degree of sophistication, can it be reached by a computer? These are some start criteria in heart failure. A patient with stable systolic heart failure should have an appropriate beta blocker. If the heart failure is complicated by ischemic heart disease, they should also have a beta blocker. And systolic heart failure with documented arterial disease should have an ACE inhibitor. So PIMS can be used in clinical research, and that requires expert clinical pharmacists or clinical pharmacologists who have full access to the medical records. PIM can also be used in large-scale medical audit and drug utilization research, in on computer files, in administrative data, or electronic records. But there are limitations as to the complexity that can be handled, and there's also some limitations in the validity of the extraction of clinical data. Here we listed fine-tuning of the definition of heart failure, NIH class 3 or 4 heart failure, whether it's combined with permanent atrial fibrillation or decompensation, hypotension, whether it's stable or not, etc., etc. All these things become very subtle diagnostic elements that are hard to extract from, as you know, sometimes ill-filled medical records. So, if we still try to implement the rule-based computer decision in electronic health records, how is this done? This is a diagram of an electronic record. That the record has lab and parameters modules, has clinical data, and has a medication management module. And it is possible to extract from the EHR that has the full information and also the historical view of the patient. We can extract at regular times a patient summary that gives us a relatively good idea of the condition of the patient at this moment, with the limited but structured information on his condition and medication list. In the dossier, in the vendor of the EHR can also provide inside the system a decision support client that can then work internally with the record and with the patient summary. The rules and the rules engine and the user interface are by the vendor, but the rule base and the knowledge base behind is proprietary and from the vendor. There are another model is that external decision support is provided from on a national platform, thoroughly reviewed, and external and independent. And this can then, through the internet, relate to the decision support client, get information from the EHR, get information from the patient summary, and provide alerts to the prescriber. The rule editor and the rule bases and the rule engines are outside the system and are controlled by a specific organization that guarantees its fairness and independence. Okay, a short word on the Optimed study in Belgium. In this study, we have extracted the medication chart from the residents from 2 nursing homes. And we only looked at the medication chart because we know that the medication chart in the nursing home is maybe the only reliable clinical information that is available. The rest, the list of diagnoses, is in our country at least, not always filled in, incomplete, unreliable, but the medication list is correct because that is used by the nurses to provide the daily medication. The extraction of the information then goes to an automatic assessment where we score all the potentially inappropriate medication criteria and calculate a PIM score. So to what extent is this prescribing appropriate or inappropriate? We can also identify all the anticholinergic medications, see whether they are highly potent or low potency, and how they were dosed, and then also calculate a degree of exposure to anticholinergics. And then also we can identify the patients, the medications that are identified to be prescribed. On the other hand, the information from the medication goes to a tool called PharmaNurse tool. It analyzes the medication list and it sums up the list of possible drug-related problems that can be observed by nurses. And it turns it into some questionnaire for the nurses. For these patients with these medications, you should check whether these symptoms are present or not. And all that information, the electronically generated PIM score, the Maranto score, and the prescribing proposals, the observations of the nurse, all go into a report that is first read by the pharmacist, who adds his comments, and then the report is electronically transferred to the physician when he comes the next time to visit in the nursing home. It will be available for him. It will be reviewed by him and the nurse, and together they will decide on changes to the medication list. And so we had we checked that in 3 nursing homes, 1 control and 2 actives. Most of them accepted it. We selected 100 residents. 3 did not use chronic medications. 3 died before the pharmacist could do the review. 2 were not, the GPs didn't turn up, or the resident died, and after the review, 6 died. It shows you something that when you conduct a study like this in a nursing home of 100 people, for 3 months, you can say, okay, in that time, maybe 10 patients can die. The conclusions of that study was that the medication review resulted in a decrease of at least 1 medication in 36%, and at least 1 possible inappropriate medication in the residents. So we could see a change, but not really spectacular. The different components of the Optimed tool, each on their own contributed to the change in the prescribed medication. When the orders were stopped, the orders for inappropriate prescribing, there's also always a risk that there are discontinuation problems, but these were limited to 2 events. Mortality was comparable between the intervention and the control group, and I think in this pilot study we were a little bit technical and oriented to the caregivers. We didn't really include the patients, and I think when proposals are made to stop medications, patients and family should also have their say. Okay, this is the publication as it just recently was published. And then I come back to the problem of quality of clinical data in residence and nursing homes. In Belgium, in Europe, and the world, we lack reliable clinical data on the medical conditions of nursing residents. During the COVID pandemic in Belgium, 2/3 of all deaths were among the nursing home residents, and they only represent 1 to 2% of the population. It was even hard to count. It was hard even to count the deaths in a timely way, and we have surprisingly little clinical data on the casualties. And that observation was made in a comment to the British Medical Journal. We think that a minimal requirement should be that every resident in a nursing home should at least have one standardized, well-structured, current patient summary with a medication list based on reliable EMR data, meaning administration data, medication administration record kept by the nurses on one hand, and a reliable clinical information and a structured patient summary on the other hand. We know now that the EMR data are available in almost all nursing homes, but the clinical data, reliable medication list, but the clinical data are not. But we can use a reliable medication list to check and improve the quality of the clinical data and the patient summary. How could we do that? Let's see whether we can use quality of prescribing criteria to check the quality of the clinical data. So not the quality of prescribing, but the quality of the record of the patient summary. Suppose you have a medication chart of an individual patient. In the EHR, the left upper corner, and also clinical data from an individual patient. From the medication chart, we can just generate clinical rules, and we can generate the list of clinical elements that we need to run the clinical rules. And the next step would be to see, are these clinical data available in this record? If the patient takes this medicine, we should know whether or not he has heart failure. It should be clear. And if it's not clear, then we can make a list of clinical elements that are missing to run the relevant clinical rules, and then reformulate that as a question to the patient or to the treating physician, and as an incentive to complete the clinical data in the medical record. And so that's how conceptually we could use the medication chart and the explicit criteria as a tool to improve the quality of the record. If we want to do something in the nursing homes, improving healthcare and the pandemic response in nursing homes with better FTC, I think crucial is to improve the quality of medical documentation and the clinical status. We can support multidisciplinary medication review. The pharmacist should not do this alone. The nurse should be involved, and the doctor should work together with the nurse and the pharmacist. We can facilitate patient and caregiver empowerment in the de-prescribing process and in the reporting of patient-related outcomes. We can enable computerized decision support and application of artificial intelligence, and enable public population research, support benchmarking and feedback activities. We can introduce the e-patient summary as a standard for minimal medical documentation, provide the nursing homes with database management systems to keep and protect local data while allowing distributed analytics. And we can provide distributed analytics for the audit of quality of medical documentation and of the quality of prescribing once that documentation has been audited, and this in a multidisciplinary medication review. Once again, the schema for doing this, we start from an EP summary. We list the potential adverse reaction checklist for the nurse. We let them observe and put all the observations in the report. We calculate the potentially inappropriate medications. We calculate the drug-drug interactions, and especially the pharmacodynamic drug-drug interactions. We show all this to the pharmacist and let them add the comments. And that brings then a full medication appropriateness report that can, by multidisciplinary decisions and together with the patient and the caregiver, lead to proposals of changes that can then be implemented and lead to a change in the e-patient summary. So that's, again, the whole structure. If every nursing homes would have a small database with all these e-summaries and the medication list, then the analytics could come from central research, from universities, or government organizations. The software to do the analysis can be distributed. The data stay in the nursing home, and the results come back to the research center. And that's, I think, a good approach to provide more quality in the nursing homes. So this brings me to the last slide with the take-home messages. Complex morbidity patterns and polypharmacy are the fate of many older adults, whether they reside in nursing homes or in community or are community dwellers. These are vulnerable patients, often with insufficient clinical documentation. A current patient summary with a reliable medication list is enough to unleash the full power of ICT-supported medication review. Good clinical data will increase the efficiency of medication review, prevent alert fatigue, and facilitate interprofessional cooperation. Better quality of prescribing could make this vulnerable population more resilient to pandemics and may reduce the pharmacodynamic interactions who have a huge impact on quality of life, much more than the pharmacokinetic who are interactions who are relatively, where the clinical problems are relatively rare in this, despite the polypharmacy. Efficacy of this approach can be demonstrated by process indicators, but also by patient-relevant outcomes, although more difficult in this population with a reduced life expectancy. And this is the reference list for some of the statements in this presentation. I thank you for your attention, and the floor is open for questions.
Thank you very much, Dr. Robert Vander Stichele, for outstanding work and presentation. Are there any questions from the audience?
Stop screen, stop sharing. Yeah. Okay. Okay. No questions? Don't be shy.
Actually, this is Lance. I have a question for you, and thank you again for your presentation. I enjoyed it last year as well. As you pointed out, the electronic health record systems in nursing homes aren't very good, or maybe are different. Let me put it that way. There are different ones out there. Are there ones that you think would be helpful, or that you have seen that are close to, you know, following the things that you've put together in your research? Or what do you think would be the really key points if a nursing home were looking to replace the system or install one that they need to keep in mind?
I think the ICT systems in the nursing homes historically have grown from personnel management and from nursing administration software, medication software. That's their historical origin. And it's only very recently that the vendors of electronic records that are from primary care got interested in the nursing home sector. It's a little bit of a forgotten sector. And there are now a few who really focus on this sector. You probably have heard of the RAI assessment instrument, the resident assessment instrument, a very complex registration system with about 400 observation variables. That is used in some of the American nursing homes, and then also in research settings in Europe. But my suggestion would be to start slow and to implement what is now the ISO standard called the International Patient Summary. It's the summary of the electronic record. We would already be very happy if that summary, that reduced form, highly structured, reduced form, if we would have a reliable e-summary from every patient in the nursing home, that will bring us all ready for the nursing home itself and for the chain of nursing homes as a real instrument of policy. I don't think you need to go much further. For the rest, there are, of course, a few excellent GP EHR systems that can easily be transported for full electronic record in the nursing home. But as a system, the e-patient summary is more than enough. Is that an answer to your question?
Yes, absolutely. Thank you very much.
Okay.
Would the system be a continuous feedback loop based on the patient's symptoms, or would there be a medication review kind of triggered to the providers and caregivers when a medication was added, or how does that work exactly?
You don't do this multidisciplinary review every day. Do it periodically, once, 2 times a year, but not much more. It's like if you have a sailing boat, you will get it out of the water every year to scrub the muscles from the cock, and it's like a cleaning operation. So this is the system I presented. The Optimeds is used as something that is done periodically in a more like within a nursing home, a project for a few days where we try, or in a month, we try to have every visiting GP do this medication review. The nurses love it. They feel really appreciated. That's what they do. They observe the patient. They are with the patient all day long, and they can see the devastating consequences of too much anticholinergics. And so that's very good that we can bring them together. Of course, if the system is some kind of automatic way of taking the sleeping pills away from the elderly, which they will not like, although the sleeping pills do nothing anymore. But we want them to get rid of it, and we want also to convince the nurses not to use antipsychotics for behavioral symptoms and in demented patients, not longer than 3 months at least. And okay, you need these kind of systems to really convince the individual nurse, the individual patient, to go there along, and you need the approval of the patient and of his family. You cannot do this in a military way. You have to have consent. Okay. It's a lot. It's even if it's ICT supported, it's still a lot of work, but it's rewarding work. And sometimes when you do a medication review and you stop a few of the medicines that are no longer necessary for some reason, or look for alternatives for anticholinergic medicines, you see really these patients labeled as dement flower up and return from a zombie life to a decent human life. Yeah. Okay.
Great. Well, thank you very much, Dr. Vander Stichele. It's fantastic work, and we appreciate you sharing your deep expertise in this with our summer interns, and we look forward to staying engaged.
It's a pleasure, and it's recorded. It will live forever. Okay.
All right. All the best. Thank you, everyone. Bye-bye.
Thank you.